This is Hugh Tilson for the Indiana University Fairbanks School of Public Health project on public health, state health officer success. It's a de Beaumont Foundation funded project supported strongly by ASTHO. And we have the privilege of talking with state health officers, current and former, about what the ingredients of success are and what the impact of turnover in state health officers might be. I've already been having a great conversation with you, Jeff Engel, former state health officer for the state of North Carolina. So let's get going and find out what you define as success. So, Jeff, thank you so much for doing this. Let's just start off with your definition of success. What is a successful state health officer?
Well, I have to look at my environment, which was the state of North Carolina. And I think in my state, the health director role is actually defined in statute. It has to be a physician licensed in that state. That's pretty much it. But in reality, in my time, I think the success was a dual role. The health director needed to wear the hat of the Surgeon General, that is the subject matter expert in the public health science of the state. And the second role was a leader and manager of a very large division within the Department of Health and Human Services, and that division being the Division of Public Health. So I think success was mainly due to wearing those two hats simultaneously and being that valued, trusted, credible public health scientist, as well as a really good manager leading a very complicated division in an even more complicated department.
So let's peel that onion back one more layer. What are the components of success for a state health officer? What has to be in place?
Well, I think it's beginning to peel that onion, if you will, beginning at the division level. The public health is mainly a science practice. We rely on data, whether it be a WIC program that we administered for USDA or communicable disease control and immunizations. You needed real solid data to do your job. So we relied, whether it was in women's and children's health or in the epidemiology sections, on really good staff, trained scientists who knew what they were doing, who could get to the health director the data in a timely fashion, but also bring with that data the stories that needed to be told about the large state. Also, being a home rule state, North Carolina needed excellent communications and relationships with local health departments. And if you didn't have that in place, you were going to fail because these health departments are autonomous. They reported to their own local health boards. They got very little in terms of resources from the state. Most of their funding was from their own tax base. And what we needed to do with them is provide them with technical assistance and quality assurance, and help lead them to make sure that all those counties and locals were rising at the same level. And then finally, so I'm painting a picture here of leading across the division down to the local department, and then finally up, which is to the Department of Health and Human Services. So a health director reports to the secretary or an undersecretary in my case, and you have to lead in that very complicated political environment.
There were so many opportunities to lead, even in your too short tenure in North Carolina. Choose your favorite, biggest, most dramatic challenge and just talk about that.
Well, I had two challenges. One was my biggest and favorite, as you said, and the other was perhaps my downfall. The first challenge was the H1N1 pandemic. And I don't mean to brag, but I was the right guy for that. Subject matter expert, infectious disease epidemiologist. I wrote the flu response plan. My team did when I was state epidemiologist. There was no more ready state health official in the United States, I would argue, than I was for the pandemic. Being a recent state epidemiologist, knowing so much and what my staff had done to put together this very, very robust plan. It was just finished too, so it was not on the shelf that long. We had exercised components of it, so I was ready to lead through that. The complicated issues of surveillance, the risk communication needed for the public, and at the same time understanding the federal asset that was coming down, which was, of course, the countermeasures in the form of either the Strategic National Stockpile, which we did not need to tap, but we had our own state stockpile of anti-flu medication. And then, of course, waiting the vaccine, which was going to take the problem off the table. That was the easy one. The hard one was the recession. It hit in 2008. I took office in 2009 in March. And the impact on the state budget hit at the same time. We had a brand new governor. We'll talk maybe more about that. But my first instruction was to put together a plan with a 5%, 7%, and 10% cut in our state line. So the budget is complicated. Our division was probably 70% federally funded and 30% state. And we had to dissect and say, well, of those dollars, what was pure state money? In other words, there was some state money, if we touched, we would lose the federal drawdown, like our maternal and child health block grant, for example. That you couldn't touch that state. So you had to look at the state dollars that were 100% state funded. We only had a few programs in that category. So I was going through that, eliminating jobs, and people lost jobs.
The leadership challenges there were many. Just tick off some of the leadership challenges that taxed you.
Well, I said the recession. We put forth our budget proposal to the governor's office. Some of it came to reality, but for your information, there were 3 large pots of pure state dollars. One was in the Children's Developmental Service Agency, CDSAs. A lot of them were federally funded, but most of those positions were pure state. We had a state oral health program, which had regional state hygienists in the schools in prevention and oral health. And the third pot of money was the Office of Minority Health. So the cuts went forward. 2 people, I believe, lost their job in minority health. We eliminated, I believe, 10 hygienists. We went after the vacancies, of course, but a couple of people lost their job. And at the CDSAs, the Children's Developmental Service Agencies, we picked at the vacancies, which is not strategic, but you do it so you're not firing people. So that was the hard part of my job, leading on that horizontal division level. The harder part was leading up into the Department of Health and Human Services and reporting to a secretary and an undersecretary. This undersecretary that I reported to was an awful person. He was mean. He also didn't know what he was doing, and he was insecure about that. And I didn't manage that well. I was intimidated by him. And all my meetings in the department were about our hot button issues, which were areas of our budget that were losing revenue, not due to any fault of our people. So our state lab was losing money. And our vital records division was losing money because they were fee-based. Both of them were fee-based, and the fees just weren't coming in because there was a recession. And also, the legislature cut the fees for people wanting, their birth or death records, whatever they needed. And they cut it so severely that it couldn't cover their own costs. So that's all I did when I went to the department, was talk about our red ink. I was never able to talk about our successes, because that's all this person wanted to hear about, because I guess that's all he was responsible for in the governor's office. So.
Lots to talk about, and I think you just answered the next question, which was, even though you were a senior seasoned state official, were there some things about the director's job that you didn't know, that you wish you'd known on day one?
Yes, I think on day one, and I had leadership training in this later, was that leading up piece into the Department of Health and Human Services, and beyond that, the governor's office. I didn't work with the governor much at all, but I did with her staff. And I wish I could have just played the politics better. And it wasn't partisan politics. It was just understanding the stresses that any elected official is under. In 2010, the legislature just completely flipped from 150 years of Democratic Party leadership to Republican leadership for the first time in 140 years or whatever it was. So we had to deal now with a whole new majority that was opposite of the party of the governor, dealing with the recession. And the other thing that you need to be a successful leader is to have that champion in the legislature, which we lost. So I was hung out to dry. I had an executive office that I couldn't trust because of this mean person that I had to report to, even though I could go to the secretary and engender his trust. A governor that was failing, and now a legislature that I didn't know, and had an agenda.
You know that one of the motivations for this study is the understanding of turnover. But what do you say publicly about your turnover?
What I say publicly is that the governor chose to appoint a new health director, and that was her privilege, and I was a political appointee, and that's what happened. That's what I tell the public, and that's what happened. What I don't tell the public, of course, is the backstory, which I really don't know, but I explored as deep as I could because I was incredibly shocked. If we can take a side moment, and I'll share that with you. It was in 2012. The secretary called me into his office, and he did that all the time. So I was out of town and made arrangements to go see him right away. And I thought it was going to be something else because he had announced that he was resigning, the secretary. And I thought he was just meeting with his division directors to tell them personally about his decision. And I thought that's what I was walking into. So I came into his office, and he said, the governor wants me to remove you from office. She wants to appoint somebody else. I'm sorry. And that was it. And talk about being pushed off the cliff. I had a visceral reaction because I wasn't expecting it. I thought I was doing a really good job. And I gasped. I went audibly like that. I'm sitting here like I am with you now. That's how shocked I was. And he said, he apologized. He told me who my replacement was going to be, which is another complicated story that's probably not necessary for this interview. And I had 90 days. That was typical of your political appointees, and you will now be a senior advisor in the Department of Health and Human Services, and you have 90 days to pack. Good luck. And so, I left the office. The first thing I did is call my wife. I was in tears. I had no plan B. which is another lesson learned there you're going to get to later in the interview. Always have a plan B if you're a state health official. And I can tell you why I didn't, because North Carolina, this was pretty much a secure job. My predecessor had it for 9 years. Her predecessor had it for 17.
You're aware of what his predecessor experienced, however.
Yes.
Let's move on with that. One of the things we're studying is the adverse impact on the agency of precipitous turnover. What happened to the agency when you came back and announced that you were leaving?
Well, I first met with my senior leaders, who were the section chiefs, and I sat them down, and I told them how shocked I was. By then, I had recovered emotionally. I had my act together, and I told them who the new health director was, and I was going to be cleaning my office out that weekend, and she will be starting on Monday. And they were shocked, and they came to me individually afterwards and just told me how sorry they were. But I think the impact on the division, which is 2,000 employees, was one of great insecurity. And they were saying, if this could happen with a sitting governor, what could happen to me, even though I'm not a political appointee? And then what happened in North Carolina after I left is that the state health director's position has been a revolving door. Nobody has served longer than a few months, 12, 15 months since I left. I was there for 3 years, so I can proudly say I was the last long-term state health director of North Carolina. So what professional would want that job now? See, when I took it, I had some sense of job security with the predecessors, as I talked to you about. And I figured I'd have to really mess up to lose this job. And I'm not going to do that. So now, what professional in their right mind would take this job in North Carolina? That's been the long-term damage.
Is there anything you could have done, anything that new state health officers can do to prepare the agency for this instability? What can we do to at least create continuity in the agency?
Yes, so I think personally the state health director needs to have that plan B and say, okay, I don't know how long this is going to last. I hope it lasts the term of the governor. But I need to have, what am I going to do? Am I going to go back to my old job, or I need to prepare for my next step? Some of this may come with very senior leaders, and they may say, hey, this is going to be my last real gig anyway. I'm going to be retiring no matter what happens to me. And that's good. But then that leaves you with a rather limited pool of aging, professionals.
So how do we prepare the agency for that? Is there something you can do to build a stable agency in the face of that?
But that's what I was getting to. So that's the personal piece, is just planning for your own succession. But the agency, thinking about this, is you should always have a succession plan in mind. I mean, you could be hit by a bus the next day. What would the division do? So I think a senior deputy is mandatory. I did not have that person. I had a chief operating officer, but he was not the senior deputy. And I think that would have been a second hat that person could have worn. We could have been doing succession planning all the time.
Let's get cheerful again. Your subsequent career has been fabulous, of course. I mean, one of the good things is that you are now a national leader in epidemiology. Talk about epidemiology in public health, and specifically the relationship of state-level epidemiology with national activity. Just bring us up to date on epidemiology.
Right. So it's been a great jump for me in Atlanta, leading the field of applied public health epidemiology, as we like to call it at the Council of State and Territorial Epidemiologists. So we have job security because our science is the core of public health. You could argue that the epidemiologists working with the laboratorian, so the lab is the other core piece, forms the foundation for almost everything else as decisions and policy go up the ladder. So we have that core science that will always be there. And I always like to say, if you look at the 10 essential services of public health, what's number one? Monitoring the health of the population. Who does the monitoring? The epidemiologists and their statisticians and their labs. So we're number one in the essential public health services. What's going on now in the whole framework nationally is that our folks are contributing in terms of the public health response to emergencies, and it's been the EOC at CDC has been open for the last 3. They're closing next week for Zika, but they were open for Ebola. They've been open for Zika. Limited activity around the hurricanes recently, but the epidemiology capacity building in public health preparedness has been a big front and center national issue. The other thing is preparing the epidemiology workforce for the 21st century. Although we're already 17 years into that century, some of our methods are still 20th century, such as just data flow, data management. And what we're really focusing on now in the field is computational science. It's called informatics, but it's really computer science and understanding the data and how to move it more accurately, more quickly, and just be more timely.
Well, that segues into the sort of end game of this interview, which is even more optimistic, or maybe not. What do you see as the greatest opportunities for public health in the coming years?
Well, I think that public health, if leveraged correctly, and you could call it Public Health 3.0, where the health director is also sort of the health negotiator for the community, and it could happen locally or at the state level or certainly nationally. Public health is really the only activity that's going to bend the health cost curve in this nation. You can talk about payment reform all you want. Pay for performance rather than fee for service. People are still going to get sick and they're still going to need care. Care is expensive. The only group that's talking about prevention, particularly of the high-cost diseases of morbidity and mortality in the United States, is public health. So if we could just get a few things done, whether it be in tobacco or banning trans fats or limiting salts or increasing physical activity in communities, that's the only thing that I can think of that's going to really impact the cost of healthcare. The ACA, as good as it was for access, really did nothing about the upstream determinants in a big way. There were a few provisions in there that were helpful, but for the most part, it was about access, and it fulfilled that promise. So the opportunity for public health going forward is really going to be that leader in Public Health 3.0.
How about a pep talk for ASTHO alumni? What happens after you've been a state health officer? Do you stop being a state health officer?
Well, I tell you what, I always look back and saying, I love that job. And I think you will always have it as that memory. And it may be the pinnacle of your career, but we're all pretty capable people, and all of us land on our feet. Even the ones where it's the terminal job, that is, they retire after they're complete, they're all active, either in the Alumni Society or they're doing consulting work. They're recognized leaders. They're always the health director or the health official. So that job instilled that in me. And I was fortunate. I'm at this, doing this national gig now in Atlanta, and I love public health. So, and I can really thank the experience that I had as a state health official.
So your last chance here, this is your bully pulpit in front of a camera to talk about talk with future shows. People are thinking about being a show, training, or new shows. What message do you want to leave them with?
Again, it depends on your state environment, but be that subject matter expert and be that good manager. But also learn how to lead up whoever you're reporting to. In my case, it was the secretary in a big umbrella agency called Health and Human Services. You may be reporting directly to the governor and maybe sitting on that cabinet. To me, that was the hardest, was that leading up. Understand the politics. Know that politics is more emotion than fact. If you're not getting along with a leader as you're leading up like I was, take that person out to lunch. Get to know them better. That was my mistake. If I could do it over again, that's what I would have done.
Dear Jeff Engel, one of my favorite state health officers in North Carolina, clearly evidence-based, perfectly qualified, a very model of a modern state health officer, and now a great success subsequently. Thank you for this interview, Jeff.
Thank you.